Great. So for those of you who are just joining us, I'd like to welcome you to our webinar, Scalable Digital Interventions to Address Mental Health During the COVID-19 Pandemic, Perspectives from the Western Pacific Region. And for those of you who have already attended in the morning and were able to participate in our keynote addresses, welcome back. I now have the pleasure to invite Dr. Jason Ligot from WHO Western Pacific Regional Office in Manila to moderate the first afternoon panel.
Thank you very much, Brian, and welcome back to all of you who are joining us for this webinar today. I'm Dr. Jason Ligot. I'm from the Mental Health Unit of the WHO Western Pacific Regional Office, and it is my pleasure to moderate this afternoon's first panel discussion. So this morning we heard some very interesting keynote presentations about digital mental health, highlighting the status of the evidence and its efficacy in addressing common mental health problems. And a speaker from the WHO also highlighted several promising interventions that are currently in development, including interventions that the WHO has already launched and is actively endorsing or promoting to our different member states. For this first panel discussion, we have invited several speakers to talk about digital mental health in practice. They will be talking about several different aspects of digital mental health, including the outcomes of a scoping review and different other factors that may have implications for its wider use in the region. So before I start the panel discussion and call on our first speaker, I'd just like to remind everyone that there will be an opportunity to raise questions, but if you have any questions, feel free to use the chat box or post a question in the Q&A. There will be an open forum later where these questions may be addressed, but we highly encourage everyone to share any questions or feedback they may have using the functions that I just described. So for our first speaker for this panel, we have, of course, Dr. Brian Hall. So Brian has been collaborating with the WHO on several different initiatives. And for this afternoon, we asked him to talk to us, to share with us the outcomes of a scoping review of mental health interventions applied during the COVID-19 pandemic. So for our first speaker, Brian, over to you.
Thanks very much, Jason. I'm just going to share my slides here. Okay, so I'm going to talk about mental health interventions applied during the COVID-19 pandemic, results from a regional scoping review. And this was an exercise that was jointly undertaken with the Western Pacific Regional Office, WHO. So mental health and psychosocial support are essential components for a comprehensive response to the COVID-19 pandemic. We know that it's challenged us in many ways, with regard to lockdowns, disruption to our daily activities, and disruption to our livelihoods. So a mental health response is a key strategy for regional member states to ensure the health of their population. So the impact of long-term disruption to mental health services may have lasting impacts on population mental health. So the WHO partnered with our research team to identify the breadth of responses to the COVID-19 pandemic to address mental health in the region. And that was during a period of rapid deployment of various mental health responses in the region. So this scoping review provides key insights into the type of interventions deployed in the early phase of the pandemic and their level of intensity. So we talked about intensity in the morning with regard to low intensity to high intensity interventions and how they were mapped on the Interagency Standing Committee guidelines or intervention pyramid. So Interagency Standing Committee is a consensus group of UN agencies and international NGOs and mental health experts that have situated guidance for the field for humanitarian response. So I wanted to cover the methods of our scoping review. We had a general broad scoping question. So what were the non-pharmacological interventions that were delivered during the COVID-19 pandemic to address mental health? And how were they delivered and by whom? And who are the potential beneficiaries and target populations? And what was the target condition or conditions that were being addressed? A study protocol was developed and approved by WHO in June of 2020, and pairs of reviewers we had for each of the 34 countries and territories in the Western Pacific region. We had pairs of reviewers that reviewed the gray and academic literature for each of those countries. And the date range was from January 1st, 2020 through June 2020, all inclusive. Our inclusion criteria for the review was that it had to highlight an intervention, whether it be a clinical intervention, a psychosocial intervention, addressing COVID-19 specifically, or an existing intervention that had been repurposed to respond to the COVID-19 pandemic occurring in the Western Pacific region, country or territory, and we left it open in terms of quantitative, qualitative, or mixed methods reports. We examined several different academic databases, PubMed, APA, PsycInfo, Embase. We also included 2 Chinese databases because, as we know, the COVID-19 was first discovered here in China, and that stimulated a rapid response within the Chinese context. We wanted to include all academic literature that we published from a Chinese perspective in the Chinese language. We also looked at gray literature. So we examined Google Scholar, government websites, including ministries of health, association websites, the psychological associations in each of the 34 countries and territories, also included trial registries and preprint databases to really scope the entire literature, either published or non-published, that focused on responses to COVID-19. We were able to identify over 23,000 academic and gray literature sources, and after a rigorous screening process, we returned a total of 166 records that met our inclusion criteria. So based on those 166 records, we found 174 interventions, unique interventions that were deployed in 22 of the 34 Western Pacific regional countries or territories. And as we see, the largest number of programs, unsurprisingly, were from China, with 55 interventions. We also noted that Australia, New Zealand, and the Philippines also rapidly deployed a number of interventions that were found in our scoping process. In terms of target populations, 46% of interventions were targeting general population, and 28% were targeting exposed populations. So individuals, COVID patients, people in quarantine, or frontline workers. Other target groups included youth and family, and students, and at-risk populations, including those that were experiencing gender-based violence, migrants, and the elderly. And we noticed that a disproportionately small number of intervention programs were actually targeting these most at-risk groups. And there was a lot of guidance and commentaries that were written early on the pandemic to really highlight the importance of these populations and how they would be disproportionately affected. In terms of intervention targets, the majority of interventions were targeting general mental health. And that means that they were targeting mental health without naming a specific disorder. So just talking about mental health, programs for mental health, and 25% of them targeted specific disorders or common mental disorders, anxiety, depression, or post-traumatic stress disorder, for example. A few interventions were targeting substance abuse, suicide, or serious mental illness. With regard to the organizations that were deploying these interventions, government departments were responsible for coordinating a third of the interventions. So governments were actively responding to COVID-19, and among a third of all of the interventions we identified, they were targeting mental health. And so I think this is an important distinction. Also, universities and university partnerships played a key role in the delivery of interventions, with over 26% of them being delivered by universities. 20% of interventions were delivered by NGOs or international NGOs and mental health organizations. With regard to intervention service providers, we see that over half of the programs or intervention programs were being delivered by specialist trained providers. So these are people who are psychiatrists, psychologists, social workers who are specialists in delivering mental health services. 20% were delivered by trained laypersons. And we know that there's been, global initiatives to really focus around training lay health workers or people without specialist training to deliver mental health services. So seeing 20% of all programs featuring this type of support, I think is promising. Self-help interventions were also commonly deployed. In terms of the modality of the intervention delivery, half of the interventions were delivered remotely, either by phone or video conferencing, and 12% of interventions were digital. So they were mobile app based. And I have an example here of a program that we worked on in China, in Macao, the Kumusta Kabayan program, which focused specifically on addressing mental health needs of Filipino overseas workers who were in Macau during the pandemic. Also, web-based online interventions comprise fewer than 10% of all interventions, and mixed mode programs were less common. So mixed mode programs meaning programs that were delivered either by telephone plus another modality. So for example, an online intervention platform. With regard to the interventions that were delivered, hotlines and chat lines were the most common. 34% of all interventions that we identified were hotlines. Most of them were existing hotlines, so suicide or existing hotlines responding to mental health that were repurposed for COVID-19. 20% of interventions were telemental health, so they involved remote therapy with professional therapists. And 12% were self-help, and the commonly delivered modality was digital apps, online psychoeducation, or referral information. We were pretty inclusive here in terms of identifying self-help, and including things like just a list of referrals to other agencies were included in this, so only 12%. Group-based interventions were less common than individual supports. So we engaged in a mapping exercise to situate these 174 unique intervention programs on the Interagency Standing Committee pyramid of services. And we'll start with level one. So level one really talks about social considerations in basic service and security. And for this level, it was primarily concerned with addressing gender-based violence, and included protection as a part of their work. So protection of vulnerable populations. Only 10% of programs were addressing mental health at the same time as attempting to address these basic needs and basic concerns. Level two is focused on strengthening community and family supports. And 28% of the programs we identified addressed interventions at this level. They focus on community communication, self-help that did not involve specialist support. So this is where lay health workers or communities were engaged in the care and support of other community members. Level three was a focused support. So that's person-to-person, non-specialized support. Mostly hotline interventions facilitated by trained lay health workers, and also psychological first aid was mapped at this level. Specialized services on level four. These are psychologists or psychiatrists or other mental health professionals, including social workers, who delivered remote telemental health services. So 33% of the interventions were mapped at that level. That's the highest level of intensity of programming available to populations. So overall conclusions of our scoping review. So during the first 6 months of the COVID-19 pandemic, 166 unique intervention programs were identified. Key gaps in service delivery were noted. So there was an uneven distribution of services to vulnerable populations, including migrants, elderly, prisoners, and minority groups. And so really, when we look at these populations in particular, we see that they're the same groups of individuals who are not receiving optimal mental health services and access to care, even in the best of conditions. And so during the COVID-19 pandemic, we see that that's been continued. Few intervention programs were targeting serious mental illness or substance abuse. And that's a key gap in terms of care delivery. A lot of work had been done to kind of raise the awareness of inpatient psychiatric patients, inpatients, and the vulnerability they were experiencing, not only to transmitting COVID-19, but also not to have their psychosocial needs met. And 22 of the 34 countries and territories reported data. So there was available data on roughly 65% of the overall territories in the region, which meant that there was a number of of countries and territories that did not report information related to a mental health response. In terms of multi-sectoral partnerships and strengthening of existing platforms, we see that there wasn't a lot of collaboration across different levels of the pyramid. There were universities that were deploying interventions primarily for students and chat functions and on hotlines. Governments were responding, international NGOs were responding. Ways of bridging these three different groups together could be potentially consequential and helpful in terms of a next wave response or preparedness for another pandemic should one occur. And broader integration across the pyramid of services can co-locate mental health services across various either community-facing engagements or engagement to protect gender-based violence, for example. Limited community involvement was also noted. So people with lived experiences weren't included in the design or deployment of interventions. Very few programs talked about planned evaluations, scale up, or inclusion of cultural factors, which we know are important for adequate mental health delivery. We also noted that remote service delivery models were common, but digital mental health programs were underutilized, which in many ways gave impetus for the conference that we're having today. So I have a few people to thank. There were a number of individuals involved in the scoping review team, and of course the WHO Western Pacific Regional Office for their technical guidance and support in this and other projects. I have a WeChat that you can scan if you'd like to follow and then be in touch, and I have my email address there. So thanks very much for your attention.
Thank you very much, Brian. And maybe later we'll have an opportunity to go back to some of the details that you presented in your report, particularly those pertaining to service disruption and how digital mental health was actually a way to overcome these challenges during the pandemic. Now, both our keynote speakers earlier touched on the importance of cultural adaptation when it comes to field testing, revising, and ultimately implementing many digital mental health interventions. To share a little bit about the cultural adaptation of a digital mental health intervention for depression among Chinese young adults, we have Hao Fong Sit from NYU Shanghai. Over to you, Millet. Hi, Millet. I think you're on mute.
Yeah, sorry.
No
hi,
problem.
Everyone.
Wonderful.
Yeah, and I'm Millet Hao Fong Sit, and I'm very honored to be here to share our cultural adaptation work of Step by Step, which is an intervention addressing depression among Chinese young adults. And this presentation will start with the background of digital mental health intervention and cultural adaptation. And then I will also share a little bit more about how we conducted the adaptation with the Chinese community and share some of the outcomes with you guys. With increasing ownership of smartphone and ease to access to the internet, digital mental health interventions could address mental health needs of diverse populations. And using this innovative technology could reduce treatment barriers such as time and geographic boundaries and treatment costs while providing timely responses to mental health needs. And culturally adapting interventions is critical to successful scalable mental health intervention implementation. We culturally adapted the intervention step by step, which is a 5-section intervention delivered on smartphone or tablet. And besides on the app version, we also provide website version for people to access. Each section lasts around 20 to 30 minutes and covers skills of stress management, activity planning, reducing avoidance coping, self-acceptance, and relapse prevention. Each participant was assigned an e-helper who provided minimal weekly support to them to check in on their condition and motivate them to continue the program. The program provided illustrated narrative story about a former service user learning how to better cope with stress, guided by a senior character, which is a doctor in the original version. So what is cultural adaptation? It's the systematic modification of an evidence-based treatment or intervention protocol, consider language, culture, and context in such a way that it is compatible with the client's cultural pattern, meaning, and cultures and values. To achieve cultural adaptation, we use the ecological validity model, which consists 8 culturally sensitive elements: language, people, metaphor, content, concept, goals, methods, and context. And the adaptation would enhance the relevance of these components to the target population's personal or life experience. The adaptation will also ensure that the program is acceptable and comprehensible for the target population while maintaining the completeness of the therapeutic component. We follow a 4-phase adaptation process. At phase 1, we set a steering group, which include experts in the field of clinical psychology and Chinese culture. The PI collaborated the intervention developer from the WHO and also engaged local community organizations. We also did 6 key informed interviews with Chinese mental health professionals who work in university, local NGO, and also hospital. At phase 2, we did the preliminary content adaptation, including text translation, storyline adaptation, and illustration creation. For storyline adaptation, it was done by a Chinese teacher based on the feedback from the key informed interview. And we also, and we adding some scenario such as conflicts with friends and family related to the Chinese young adults. We also hired a Chinese illustrator to create the illustrations for the sections. With these preliminary materials, we conducted 18 focus group discussions with local and non-local male and female Chinese university students in Macau. And then based on their feedback, we further adapted the materials, the text and the illustrations. And we displayed this material to them across the meeting. At phase 4, we brought the finalized adapted materials to the community feedback meetings to ensure that the adapted materials were what they wanted. So let me share some of the outcomes with you here. So for language, of course, we did a translation from English to Chinese, and we provided traditional Chinese for local group and simplified Chinese for non-local group who are from mainland Chinese. And it pointed out some issue related to the translation or the story. For example, they think that the expression of the welcome message was redundant. Then they provide a more concise version, which English translation is, "We welcome you to come back to session 1, and we can prepare for the next step," to enhance the comprehensibility. There is also a problem, which is related to accessibility, is that they think that the encouragement messages appear so often, but in Chinese culture, people seldom praise people verbally. So they just think that it's too many, well done, good job, and congratulations, this kind of messages. But since step by step is an intervention designed for depression, and we know that people with depressive symptoms need motivation to do things because of their symptoms. Sometimes they don't think they can do things, and we really need to make sure that they can continue the program. That's why we want to keep these encouragement messages. So the focus group suggested that perhaps we can use illustration for this purpose. With this illustration, then the test won't look strange. And this illustration is also a adaptation outcome of people. In the original version, it is a doctor figure, but they think that it's not acceptable to use doctor because it's related to some stigma. So we modified it to a peer female for female group, and then a cartoon or non-human figure for male group to replace the doctor figure. We also added or removed some metaphor to enhance relevance, accessibility, and comprehensibility. For example, there's a scenario about the mother asking the main character to help with housework, and they think that it's not clear enough and not relevant enough to their life experience, and they suggest the modification, which is helping your room, it looks like a doghouse. And doghouse is a metaphor for an untidy room in Chinese, and was commonly heard from a parent, especially heard from mom. And there's also some other problem related to metaphors, that is too abstract or exaggerating. And they modified it to a ton of invisible pressure falls on you for this one. Or they just use I could finally sleep well. So they prefer some plain language instead of complex metaphors. Content in step-by-step includes narratives, characters, and illustrations. And we add a problem in dealing with non-contributing teammates in group projects because our target population is young adults, and most of them, they are college students. And we also modified the narrative by adjust the elements of the story. And these elements were also illustrated. For example, the transportation, their interaction with friends, and also the place that they like to go. We also modify a friend character in male version to make his appearance look more masculine and attractive. These two are the main character in female version and male version, and this is their Chinese name. And they were anticipated a change of appearance across the section to show that they become better after joining the program. We can see that in later section, they look more confident and they wear colorful outfits. Besides the illustration I shown you, the focus group also suggests illustrations for some concept or ideas. For example, this one, a hand holding in heart, which means that accepting help from the others can make their life feel better. We also modify the concept to make it more relevant to their life experience, easier to understand, and make it, sound like symptom, And from the key informant interview and focus group discussion, they think that this program is suitable for mild and moderate depression and anxiety, but it is important to frame the program as stress management tool or something related to academic performance to reduce stigma and to enhance its accessibility in the Chinese community. Here is the conclusion and some taking message for you guys. First of all, we think that a proper framework and a rigorous process are essential for cultural adaptation. And it is important to hear from both experts and members of the target population in order to achieve the successful cultural adaptation. Including layperson with similar characteristics in groups in a cultural adaptation could enhance the validity of the intervention. Also, we think that community engagement is key to successful cultural adaptation as well as intervention implementation. Without community engagement, we won't be able to reach the local community that easily or quickly. Finally, culturally adapted interventions need to be evaluated to know its efficacy and effectiveness. That's all for my presentation. Thank you for your patience.
Thank you very much. And later on, we'll have an opportunity to follow through with some questions or comments from our participants. But offhand, I really appreciate how you showed how complicated actually the process of adaptation is and how much an intervention can change as we take into account a lot of local nuances with the language and with the imagery. So congratulations to your group for shepherding that process, and we look forward to discussing that a bit more in detail later during the open forum. But speaking of implementation, the discipline of implementation science has actually grown a lot over the years, and this is a very important area, especially when we consider how we can scale up and adapt these various digital mental health interventions across different settings in the region and for particular vulnerable groups. To share with us their experience in scaling up digital mental health interventions, focusing on a particular intervention that was implemented in Macau, we have Mr. Adrian Liam from the University of Macau. Over to you.
Thank you, Dr. Ligot. I will share my screen. Could you see my PowerPoint?
Yes, very clear.
Okay, I will make it reading view first. Okay, good afternoon, everyone. Thank you for your attendance here. And I would like to share our work here in Macau, but especially we will learn about implementation science approaches to scale digital mental health interventions. And we will learn from Kumusta Kabayan in Macau. Specifically, we will learn together about what is implementation science and why it is important, and we also look briefly about its approaches, and then I will use Kumusta Kabayan as an example of how we implemented implementation science here. And we also will hear about hybrid effectiveness implementation designs and also the specific framework that we use, which is a WE-AIM framework. So implementation science came from the medical world, where the researcher looked at why some robust evidence-based intervention failed to be used by the people, and some of the intervention also were not sustainable. So for example, it's very good, or the finding is very effective, but when people in the market use it, they might not like in some aspects, so they leave it. So for example, if we use a finding from the systematic review, we know that digital psychological interventions are superior to control condition and are moderately effective in low and middle income countries. But the studies that being reviewed in this article based on community sample or clinical sample. And how do we know or sure when the program delivered to public, it will be used by the people, or it will be lost the momentum? So that's why implementation science then come as define scientific study of methods to promote the systematic uptake of research findings and other evidence-based practices into routine practice, and hence to improve the quality and effectiveness of these health services or program that already researched. So there are three primary aims for implementation science. First is to describe or to guide the process of translating the research into practice, the real world, and then to understand or explain what influences implementation outcomes. And the third aim is evaluating the implementation itself. And there are 5 categories within these 3 aims. First is process model, which is specify the steps or stages in the translation process from the evidence-based research to the real practice, the real world. And then there are three categories in under the understand or explaining the influences of implementation outcomes, which is a determinant framework, is to know the barriers and the enablers that influence the implementation. And then classic theories category, we use the existing well-known theories from, for example, psychology, sociology, and other fields to explain about the implementation outcomes. And then the fourth category is implementation theories, which is an extension from the classic theories, or we can create a new theories to explain or understand the implementation outcomes. And the fifth category under the evaluating implementation is to evaluate the frameworks. So it's a specify aspects of implementation that could be evaluated. Here are some examples for each category, and maybe some of you are familiar with one sample, or maybe some examples already used in your research. And later we will discuss more about re-aim under the evaluation frameworks. So when we talk about digital mental health, this systematic review find that there are barrier and facilitator factors that could affect implementation of digital intervention. The first barrier that they found is financial aspect, specifically high upfront and maintenance costs that could be a barrier to implement the digital intervention. And then if the program is too complex for the user to use it, they will just leave it, or it's difficult to be accessed, and yeah, that will be a barrier as well. And also people with low IQ might be difficult to use the digital intervention. Same with people with low IT skills or digital literacy. And in some implementation, the researchers might work with other stakeholders, like a local partner, for example. And if the members have like a poor IT skills, or the partner have a negative view or perspective toward digital intervention, and maybe they have also a resistance to the change or digital intervention in general. However, there are some enablers or facilitators that could help in implementing digital intervention. For example, the program is user-friendly, easy to be used, and can be personalized for based on what users need. And then compatible with existing system. For example, the keynote speakers mentioned about the step care model. So if the digital intervention could be embedded to the existing services, it will be very helpful, and also adaptable to the local environment and the user condition as well. And also it's important if the digital intervention is supported by the policymakers and also the current regulations. So now we are moving to hybrid designs. This is the well-known pipeline research from efficacy studies to the implementation in the real world. So one study found that it could be more than a decade from findings in efficacy studies to be implemented fully in the real world. So the significant amount of time could be reduced if we then apply these hybrid designs. There are three types of designs. But what is hybrid designs? So this designed to promote examination of both effectiveness, if you see in the middle, and the implementation outcomes within a study. So in one study, we will look the effectiveness and also how the implementation itself. And if you see the pipeline, there are three boxes with different outlines. The first one, hybrid type 1, so more on effectiveness studies and a little bit on implementation, because the primary aim or focus is on testing the clinical interventions. With secondary focus, we want to explore the implementation related factors. And the hybrid type 2, if you see the boxes there, it's a quite balanced in effectiveness and implementation research, because we want to know the clinical interventions and also the implementation related factor. And lastly, hybrid type 3, more on the implementation research, because mostly the research using this design, the participants will be like the professional helpers or the provider, rather than the clients or participants that use the app or whatever digital mental health interventions given. Okay. So now we are moving on the Kumusta Kabayan. This is a Filipino version of step-by-step that already explained very well by Dr. Carswell in the first session. And then my colleague Millet also explained more about the content. So Kumusta Kabayan has been culturally adapted by my colleague Dr. Melissa Garabils, who also among us today. This intervention based on behavioral activation, and then the story itself and the illustration have been culturally adapted. If you remember Millet's presentation, the illustrations are different. And we have two versions based on users' sex. So when they register themselves, we will ask what is their sex. If male, then we will provide the male version. You can see Kuya Ronald here as the wise or older overseas Filipino workers, because we don't want to use a GP character, because might have a distance from the user perspective. And if the user is female, then we will give the female version. There will be Ate Sonia and Leona. So Leona and John is the younger character, represent the user as Filipino workers, overseas Filipino workers. So we use hybrid type 1 in our pilot study, because as Dr. Carswell mentioned in the previous session, that the step-by-step already trialed in different studies, but the characteristic of participants are quite different, because our participants here are migrant workers, but the previous study show it's effective to reduce the depression. So with that characteristic, that the intervention has been supported by limited evidence and different participants in current research. And then we culturally adapted the Kumusta Kabayan. So that's why we use this hybrid type 1. And how then we implemented the implementation science. So we use this framework, reach, efficacy or effectiveness, adoption, implementation, and maintenance. That's the REAM standing for. So for R and E, the effectiveness is like the regular or ordinary effectiveness study or pilot study, because we want to know the effectiveness of the study, the program, and then it's extended to aim. A is adoption, like what is the barriers, enablers of Kumusta Kabayan adoption into community partner program. And then the I, or the implementation, is the core of this aim framework. We want to know also what is the barrier in implementing Kumusta Kabayan and how to maximize the implementation. And then not only not stop on that. We also want to know how to maintain that, to make the Kumusta Kabayan sustain in to be used by our participants. The outcome measurements for the effectiveness, we use psychological measurements like AP9, JD7, and WHO5 will be indexed. But because we want to explore the implementation as well, so we have some measurements like the stakeholder acceptability survey, the attitude of the our partners toward digital mental health intervention, and then our e-helpers, because we also have e-helpers from the Philippine students. So we want to know their opinion as well. What is the barrier in helping or when they become the e-helpers? So we work with multiple stakeholders. That's important in the implementation science, because we want to know all stakeholders' perspective to make sure that our program can be implemented and sustained in the long run. So beside the participants who completed the program and also people who did not complete the programs, because both of these groups are important, and also our e-helpers, and then the local partner, the executive, the staff members, and also some volunteers who help us in reaching out the participants, because there are in RE-M frameworks, we also consider what is the best way to reach the participants to promote this program. And we do like, we collect data from survey and also do the qualitative study by interviewing and also the focus group discussion. So some take-home message that implementation science is the science of making intervention and program effective in real-world context. And by using implementation science, we are involving many stakeholders, multi-stakeholders, not only the participants, but also the supporting units, organization, also the policymakers, funding agency, and all stakeholders that can be that involved in our study, from the planning until the execution and the evaluation. And this interactive and multidisciplines action will identify the barrier and also the enable factors, aspects, and hopefully it will helping in maintain and scale up the digital intervention. And there are three approaches in doing implementation science, depends on the aim of the research to describe or guide the process of the translating research, or to understand or explain what factors influence the implementation outcomes, or to evaluate the implementation. And hopefully by maintaining and scaling up the digital mental health intervention, it is expected that it will improve digital literacy, among participants and the staff member, and also improve the equitable digital access. Because in the keynote speakers, digital mental health mainly developed in North America and European countries, but hopefully by doing implementation science, it can be effectively implemented well also in global south area. So that's all from me. Thank you.
Thank you very much, Adrian, and a very clear framework that you shared with us this afternoon on how to conduct this hybrid approach to implementation science. At this point, I'd just like to remind our panelists and our attendees as well that if you have any questions or comments from the presentations that you'll hear from this morning through to the afternoon, please feel free to use the chat box or raise a question in the Q&A. Now, one of the factors that our previous speaker highlighted in terms of the challenges of implementing digital mental health interventions is the skills or the IT skills of the staff themselves in implementing digital mental health programs or actions. Speaking from my own personal experience as someone who has had encountered challenges with IT, I think getting a better grasp of or an idea of how to work with software developers will be very helpful for all of us in the mental health field in actually designing, implementing, and evaluating these different interventions that we've been discussing since the morning. So to talk to us about how can we work with these software developers to create digital mental health solutions, we have Mr. Sebastian Buchert from Berlin to talk to us about this very important topic. So over to you, Sebastian.
Thank you very much. Can you all hear me well?
Yes, great. Loud and clear.
Before I start, just looking at the time, there's another speaker after me, right? And I think we only have until 30. Is that correct? Should I try to keep it concise?
Well, yes, but we can make some adjustments because after this we have an open forum, so we can be a little bit flexible with the time. But okay. Yes, if we could kindly request you to try to be concise with your presentation, just the same.
Yeah, sure. Thank you very much for the invitation, for the opportunity to speak here. I'm a researcher from Berlin. For more than 6 years now, I am working at the cross-section of psychology and informatics, working on developing IT infrastructure for e-mental health projects. And in this presentation, I'd like to share a few of the insights that I've learned over the years that I think that may be helpful for those planning or who are already working with software developers. Just a look at the different technologies that we can apply in e-mental health. There are many different ones. Some of them already have established systems. Some of them need to be developed, some from scratch. So everything from email to smartphone apps, over wearables, chatbots, VR, AI, and things like that are technologies that are interesting in e-mental health to provide a medium for translating effective treatment approaches into e-mental health solutions. All of this opens up, of course, interesting new opportunities to provide support to people who are currently not receiving sufficient e-mental or mental health support. But as I was already mentioned, these also come with significant challenges. And one of the main challenges that often occurs is working with software developers. Actually, I would like to say a little bit more general. Actually, the challenge is not so much working with software developers, in my opinion, but working in multidisciplinary teams. That's something new introduced when working in e-mental health, that, for example, as therapists, psychologists, psychiatrists, we cannot just create these solutions on our own. We need to work with other people from other professions that have a different way of looking at things and different way of communicating. And so you might find yourself working with healthcare system stakeholders, designers, artists, data science, data protection experts, lawyers, and of course also people involved in software development. And as you can already see on the slide, I'd like to specify this a little bit because I think that's one of the very first and important things to understand when entering the field of software development. And that is roles in software development, because there's just not the one software developer. There are actually different levels of experience and different tasks in software development. So one of the first things that's important to know is that a programmer is not necessarily the best person to talk to at the start of an e-mental health project. And it's important to know the difference between programmers here, which is basically someone who can code in at least one programming language, and that's it. Software developers who are more experienced and who can also conceptualize software components or packages of software, who can also design it. For example, a communication feature for an app. And then there are software engineers. Those are the most senior, the most experienced software developers who are able to design whole software systems that we usually need in e-mental health. So a whole set of software components that need to work together to provide an intervention, for example. And then there are some associated professions like designers who create interfaces and project managers whose primary job is to make sure that the communication between customers and developers works well. Now, when you are planning an e-mental health project from scratch, it is extremely essential that you start working with software engineers, that you find someone who has the bigger picture. And it is also essential to work with professionals. What often destroys these projects is that you know someone who can code and think that that's sufficient to create an e-mental health solution. It is not. You will need someone who has the bigger picture and who knows the different systems and can help you make decisions. And another very important thing here is to work with teams and not with individuals, because staff turnover can kill an e-mental health project if you lose your developer. Now, after looking at the roles in software development, it's also important to understand the process. Here's a common depiction of software development. It's a circle, and that's very important. It starts with the analysis. I will get into more detail in a couple of seconds. Then continues with design, implementation, testing, release, maintenance. And the key thing here is it doesn't stop at that point. It continues. So software development needs to be understood as an iterative process. It's not done once and then it's done, but it needs to be done in circles. And in this process, communication is key. That's also the major challenge working with software development. And here's a very famous illustration of this. It's the world famous tree swing cartoon or comic. It's very old. It dates back to the 1960s when software development starts, and it basically illustrates the key problem that everyone working on a software development project has a different view and opinion on what is needed. Up here, you see, for example, how the customer explained what she needed. This is how the project lead understood it. This is what the programmer eventually wrote. This is what the business consultant described it to be. This is how it was documented, not at all. And over here, that's the most important part. That is what the customer really needed. And this is very old, as I said. Here's the first printed version from 1973. It dates back to the 60s. This is basically what almost every software development project struggles with, is getting the requirements right. So the most important thing to do and to know is that you need to write a very concise, precise SRS, a software requirement specification for your project. And that's a document that basically answers 3 questions, the ones you see here. And it especially focuses on a detailed description of functional and non-functional requirements. So the 3 questions that this document needs to answer is the context. So why is the software needed? You should have a clear answer to that. Function requirements means what the software should do. And non-functional requirements, how the software should do what it does. And let me get into a bit of detail on that. The context analysis is, as I said before, explaining why it's needed. So this includes a needs analysis in the target population. Here's just an example from a previous project. So for example, you might have an Arabic-speaking refugee population with limited access to the local healthcare system in the country. There are several barriers to seeking care, for example, the language or fear of stigmatization, but there is a high tech literacy and good access to smartphones and the internet. That's like a short, concise context description. And then you would need to take a look at the available solutions to this population. For example, there could be no low threshold smartphone-based mental health programs available in Arabic. So it might be a good idea to create that to address the barriers to seeking care. And the software requirements document should outline this context first. Next, you would describe the functional requirements. And the functional requirements basically include the roles, so the people who need to work with your program. And a very helpful technique then to describe the specific features needed are user stories. So a role description could read like this. For example, you specify the role of a helper in an e-mental health program. The helper supports clients throughout the intervention. Helpers write feedback text in Arabic, for example, and adjust the course and content of the treatment to align with the client's needs. That's a short description of a role. And then you use these roles in so-called user stories. They have a specified format. As a role, I want to goal or desire what the software needs to do, so that benefit, that means why is it needed? What is the advantage of having this feature? And then you can use this generic format and your roles to write down a full, complete list of all the features you need. For example, as a helper, I want to see clients' inputs in exercises, so the interactive exercise of an e-mental health solution, so that I can provide individualized feedback. Or another example, as a client, that's another role, I want to track my symptoms and activities in daily life so I can get insights into what improves my symptoms and what makes them worse. These are examples for user stories, and they are very well understood by software developers. And to the non-functional requirements, these are basically based on the context, and they basically describe characteristics of the program. For example, what platforms it is available for, what security measures need to be in place, what languages, and also, of course, the whole area of usability covers non-functional requirements. When it comes to the design, it is very helpful to create your own wireframes or mockups. That means like sketches as well, like short, small illustrations on how you imagine the program to look like, what elements you think are necessary, and how they should be displayed. This helps developers and designers a lot in getting started. And that's something you already heard about when it comes to contextual adaptation, for example. It is very important to apply user-centered design methods to make sure that the programs you develop are actually relevant. Now let me wrap up with two important topics that always come up in programming and working with software developers. One is money, and the other one is time. Money applies at several stages of software development, and it is just a fact that software development is expensive and that you need a realistic budget before getting into software development. There are several different types of costs, like consulting costs, coordination costs, the initial development costs, but also costs that are often forgotten, like documentation costs, ongoing costs for hosting and maintenance, and costs of change requests. And you should account for all of these types and especially try to avoid change requests. Change requests are changes to the code that you need later on once it's done. And they are usually very expensive because the software developers know that they are the only ones who can do them. And they also often require lots of work and testing to make sure nothing's broken by making that change. The other important thing is time. It is very important to allocate enough time for development, but also for testing and for the release of the software. So one important thing that's often forgotten is that it also takes time to release, for example, apps on the Play and App Store, because these apps need to be reviewed by Google and Apple first. And it is also important to keep enough time to keep your user-centered approach, because there's a connection between time and your willingness to change things in your software. If time's already out, then you will be very reluctant to make changes, even though they might actually be required. And you will rather say that the program's good enough and the error using it is with the users. While if you have sufficient time, you might say, okay, let's get back to the programming and change things. And the final advice here is when it comes to time is that don't forget that software also has an expiration date, like any medication. It's not like a pill that you can produce again and then the expiration date is going to be set. But if you develop a software today, it is most likely going to be outdated in 5 years from now. And that is something you should discuss with your developers to make sure that the service period is what you imagine. And it's also something that needs to be made clear to clients so they know for how long they can expect to use the system. Last slide, a short summary with some important questions that may help you getting started. Before starting software development, it is very helpful to ask yourself, what do I need? When do I need it? And for how long do I need it? And then to make a decision on make or buy. This is also very important. If there's already a software that does what you need, then it is always better to use that instead of developing from scratch. And you should also take a look at whether you can modify existing software. That is also better than starting from scratch. And then, of course, you need to make sure that you have sufficient funds, not only for development, but also for hosting and maintenance, which can be relatively expensive over time. And I think with this, I've shared my insights, and yeah, thank you very much. And if there are any questions, I will unfortunately not be able to join later, but you can send me an email and I will be happy to answer your questions.
Thank you very much, Sebastian. Again, a very clear description of the process of software development, and just picking up those three main points: making sure you have enough time, enough resources, and the right people to actually do it. And in fact, I think what you've highlighted it in your presentation is that for a successful digital mental health solution, you have to work with a cross-disciplinary team, not just good software developers, but a good technical team as well, to bring together all their different perspectives and talents. So as I mentioned earlier, we're making just a simple, quick adjustment in the program. So we will just adjust the timings for the open forums, but I note that our keynote speakers are with us already, joining in from Europe. So thank you very much. We have one more speaker for this panel, and then we'll go straight to the open forum and the second panel after that. So as we know, the COVID-19 pandemic has accelerated a lot of trends in terms of the digital adaptation of populations. But alongside this rapid rise in the use of digital tools and technologies are also concerns regarding around trust for disruptive technologies. To talk to us a little bit more about that, we have Mr. Marcus Schweitzer from Deloitte. So hello, Marcus, please, over to you.
Thank you, Jason, and thank you, Brian, and the entire team for having us. Some really interesting topics and conversations that we've seen so far. So my name is Marcus. I am an expert in analytics and AI at Deloitte, and I'm also the fellow for disruptive technology in mental health at the World Economic Forum. And I wanted to give you guys a sneak peek at a project that is going to be launched next week, which is the Global Governance Toolkit for Digital Mental Health. So the toolkit is designed for governments and regulators, soft and hard standard setters, digital mental health innovators, healthcare, and investors in digital mental health solutions. And it's designed to encourage solutions and services and tools that are safe, that are trusted, that are efficacious, with the ultimate goal of helping consumers and carers and communities to be able to use and make use of safe and quality tools. And I'll go through each of the key concepts that are going to be appearing in the toolkit. I'm going to shoot through the landscaping slides pretty quickly. I don't think we have to talk too much about how big of a problem mental ill health is, but from a personal side, everyone I know, and I'm sure everyone here knows someone who deals with or has lived experience of mental ill health. And for me, that's my brother, who I care for part-time, who has lived with schizophrenia for 15 years. So what are we talking about when we talk about disruptive technology and mental health? Really, it is the application of quite new techniques using cognitive AI, big data, augmented reality onto existing tools in e-mental health, or more recently, the term digital mental health or digital behavioral health. And really, these tools have been developed for other applications, and mental health is uniquely sensitive, it's uniquely personal, and it's a uniquely human subject. We did for this project, we did a strategic analysis of about 190 global use cases of digital mental health or disruptive technology. And just to shoot through a few of them quickly, you've already heard a few. ICBT, or Internet Cognitive Behavioral Therapy, has been around for about 10 years, and you've seen that it has been shown to be efficacious. There are chatbots that you can talk to that purport to mimic psychologists and psychological conversations. There are gamified treatments that say they can diagnose certain mental ill health disorders with 100% accuracy and 100% specificity, just tracking people's behaviors as they interact with the game. Digital phenotyping is creating huge behavioral health data sets. They're tracking what we are doing and who we're talking to every day, and they're creating a data set that we can base new research on and bring the intervention as close as possible to the situation. There is augmented reality that's really creating new ways of treating different illnesses. There's computational psychiatry that is unearthing new ideas about biopsychosocial cause and effect within mental health. And right now you can get an implantable in your head that will turn off the section of your brain that's associated with addiction. So there's some pretty extraordinary services that are coming out, and they bring a lot of promise, and the number one promise is new treatment modalities and better accessibility to treatments. You could call it the Uberization of mental health, where you can access these services in the privacy of your own home, in your car. You don't have to take the 45 minutes and book an appointment. They are more affordable and they're more scalable. And then new research and new treatment options, which even if 5 to 10% of these new options are actually efficacious, we're still sort of flipping the traditional thoughts on how to treat mental illness. The other ideas are that they are less, you can interact with them without the same stigma or discrimination. They have similar clinical efficacy, and they are unearthing data sets for which we can make better strategic decisions about our population's mental ill health. The fundamental question for us, though, was why hasn't it been widely adopted and why isn't it widely trusted? And through this project, we've engaged about 100 experts and executives and innovators and NGOs around the world. We also did a research and literature review, and there's a lot of concerns about digital mental health. Primarily among clinicians, it is a concern about efficacy. And those 190 use cases that I showed before, only 11% of them had actually had randomized control trials that were peer-reviewed and published about those particular services. The number one concern from consumers tends to be about data privacy. Is my data going to be misused by advertisers, by judiciary services, by insurance, or by governments? And then there are a suite of other concerns about, we've seen the effect of bias in artificial intelligence applied to health settings, where the applicability of the treatment isn't directed at the cultural or social situation of the particular consumer. There's accountability questions when these digital services are going across global international lines. And there's a question on both sides. Are we widening the digital divide because not everyone can access an iPhone that can actually provide these services? And the other side of that is, are we making people more addicted to digital-only interactions, especially in mental health, where your social interactions and your community is so important to your outcomes? So we had a look at these trust issues that were preventing widespread adoption. And we also had a bit of a scan of what the other countries or soft and hard standard setters are doing in this space, including working with the New Zealand Ministry of Health to trial the standards that you're going to see in a minute. And there are some, mixed reviews. Some of them are quite highly burdensome in terms of getting through the review, and some of them don't cover all of the domains of concern that people have about these services. So when we went about creating principles and standards in this space, we went about it in a co-design model. And we started with what are the goals that we want to achieve. We co-designed with those 100 executives, as well as with the New Zealand Ministry of Health and with consumers. And we identified healthy individuals, healthy communities that can support those people, and a healthy population supported by a thriving mental health ecosystem, not just a digital mental health ecosystem. And then the important values that people saw when they thought about digital mental health services. Are they efficacious? Are they ethical? Do they promote equitable outcomes? Are they safe, sustainable? and are they actually usable day to day? And ultimately, can we trust these services with our secrets that we would typically trust a psychiatrist or a psychologist with? So we created the goal and the values and some of the attributes that make for really great digital mental health services, that they're integrated, culturally fit, that they're demand driven, etc. And we combined that with the domain of risks from our research, as well as looking at some of the current best practices in standards and principles. And we came out with these 16 principles. Each principle is backed by 3 to 10 standards, and they are comprehensive, they're broad-based, and they're really risk-based. Covering topics like artificial intelligence and machine learning, person-centered design, social and cultural respect, and practice with evidence, and data privacy and transparency. So I'm not going to break down all of these, but let's just break down one of them. If we look at leading practice with evidence, we have that principle. It is backed by 3 standards, utilizing clinically validated therapeutic models of care, offering content and therapeutic approaches based on science, and supporting ethical research and publication. And then each of those standards has a requirement which is outcome-based or goal-focused. A code of ethics is applicable to humans practicing mental health treatment, but when it comes to digital services, you should generally go down more of a standards path without being prescriptive of how to meet that standard, just the standard that should be met. So they're outcome-based requirements that can be scored against. That scoring can create a rubric against the original values so that it's easy to read for users or clinicians. And then there is also a sense of flexibility in the application of these standards, because some standards are not always applicable in all cases. And there is so there has to be a pre-classification event before applying the standards to the digital mental health services. We also came up with the challenge that there are always unforeseen ethical challenges when applying new techniques or new technology into the mental health space. And so we've put forward this methodology for dealing with those ethical dilemmas. And the example that we worked with was an organization in Israel that was looking at how to create an intervention system for adolescents posting about suicide on social media. It might seem sort of obvious that if someone posts about suicide, we should do some sort of intervention, but there are questions of, okay, if they post about suicide, we intervene, but what about body dysmorphia or bullying or low-level anxiety? At what level do we intervene? And what is the acceptable level of intervention? Is it an ambulance outside your door, or is it a phone call, or is it just a pop-up on your screen as you're working through your social media account? So this methodology has 2 key components. Number one, it's using those modeling and analysis techniques that you already use when implementing analytics or AI in a service. But instead of modeling the functional outcome, you're also modeling the ethical outcome of the service that you're providing. And so that might be in the form of clinical outcomes, it might be in the form of social or financial outcomes. The other side of it is to co-design, co-work with the community that you're implementing with to understand what is acceptable and unacceptable. And so using the data and that co-design to come up with answers. Of course, when you're faced with an ethical dilemma, if you do not answer that dilemma, you are choosing not to answer that dilemma. Some of the other concepts that we go through in the toolkit is taking those standards and operationalizing them in different jurisdictions. Our hope is to really drive opportunities and pilots in a number of countries. So we've already piloted in New Zealand, and we're looking at a number of other options to pilot those standards. When putting them in place in different jurisdictions, the first thing you need is an evaluation framework. That's the actual implementation of those standards. But there are also important questions about level of regulation, who is going to own that, and really important is not making these standards punitive or restrictive, but actually making them an incentivization for the growth of digital mental health within the ecosystem. As we've already seen, there is a high amount of importance and opportunity in applying these digital services to countries that don't have existing mental health services. And we want that to grow, but we want it to grow safely and with high quality. So what are the options there to actually incentivize these services? So our goal, and hope that you all join us, is number one, piloting the toolkit with standard setters, soft and hard standard setters in different jurisdictions, as well as with service innovators, so digital mental health service providers, gathering feedback on these standards and sharing that with us as we develop them in our journey in the next step, and to continue to grow that community and promote, adopt safe, trusted, and strategic digital mental health. And my email is up there on the screen if you would like to get in contact with me. Thank you very much.
Thank you very much, Marcus, and we look forward to learning more as you roll out this global toolkit for digital mental health governance and finding more about the outcomes.